Good evening, everyone. Welcome to Pediatrics by Dr. Anand. Is my voice audible to everyone? Please let me know in the comment section. Good evening to beautiful, amazing people. How are you, everyone? क्या चल रहा life में? How are you doing, my dear friends? I hope my voice is audible to everyone. Please let me know if my voice is coming. Yes, I'm saying, my voice is coming to me now. I hope my voice is audible to everyone. Amazing people. Good evening, everyone. First of all, a very happy Guru Purnima. May God give you everything in life. May you study, shine, and be bright as amazing, beautiful personality. And may you inspire some amazing million people and the beautiful generation ahead of you. सो हैप्पी गुरु पूर्णिमा टू एवरीवन. शुभम का मैसेज भी आया था, ओसामा का मैसेज भी आया था, सबका मैसेज आया था. यस, we have amazing people. Hello, Dr. Vaibhav, Rahul, Osama, Shubhangi, Pandey, Amrit, awesome, Karan, so many people. Great. Good evening, everyone. May God give you everything in life. Let's start this beautiful class. My name is Dr. Anand. I have done my MBBS from Ambedkar Medical College, Rajiv Gandhi University, Health Sciences in Bangalore, and I've done my MD from Tirthankar Mahavir University, Muradabad. I'm working as an assistant professor with a beautiful, amazing teaching experience. We teach to UG and PG students and also students applying for DM and MRCPCH. Today's topic of choice is cardiology, and cardiology, most importantly, today is the easiest topic on this planet. A very light topic. We have PDA, patent ductus arteriosus. PDA is a UG topic, it is an intern topic, it is a clinical topic. Very commonly asked questions on PDA. We're going to cover it in a very nice way. Before starting any amazing segment, we always have a motivating quote, and today's beautiful motivating quote is, what is the quote? The quote is, you are the writer of your own story. You are the writer of your own story. So write something amazing. So this is a beautiful, strong quote of the evening, bro. You are the writer of your own story, man. So you're gonna write something amazing, okay? I am the writer of my own story. I am going to gym. I have joined guitar classes. Sunday I go to dance classes. I love studying. I love teaching, and I'm very good in my job. So I am the writer of my own story. So you are the writer of your own story. Write something amazing. Be a different personality. Okay. Just realize your own potential and just be crazy. Don't. There was a saying. Don't settle down for just okay. Okay, be amazing, be awesome, choose the best, and don't just settle down for average. You were born for the perfect thing, and you will be amazing. You just have to realize that how beautiful God has made you. Okay, so do you agree, yes or no? Dr. Amrit says a pure Amrit bada pyara lik raha hai. Very beautifully Amrit is writing. When you start writing something also, I can get the good vibes. Good vibes. That's just like genuinely he has written. Like we have our student Dr. Shubham, Shubhangi, Osama. They are like genuinely very concerned about me, genuinely come to the class, genuinely helping out each other like a family. So they are like genuine people, and Amrit also is one of them. And Amrit says, a pure respect for you. As long as I live, may my respect towards you sustain. Oh, क्या बात है, सुन के बड़ा अच्छा लगा. So it's amazing. Okay, great. Let's start this beautiful class. And as on the occasion of Guru Purnima, Dr. Osama has a very beautiful thing I'll quickly gonna say. In Hindi, Dr. Osama says basically, जिसके प्रति मन में सम्मान होता है, जिसके प्रति मन में सम्मान होता है, जिसकी डांट में भी क्या अटूट ज्ञान होता है. हाई फाई. सो जिसके प्रति मन में सम्मान होता है, जिसकी डांट में भी एक अटूट ज्ञान होता है, जन्म देता है कई महान शख्सियतों को, जन्म देता है कई महान शख्सियतों को, वो गुरु तो सबसे महान होता है. ब्यूटीफुल, ब्यूटी आपके शब्दों में क्या आ रही है? मिठास, मिठास, मिठास. थैंक यू डॉक्टर ओसामा. लेट्स स्टार्ट दिस ब्यूटीफुल क्लास. टुडेज टॉपिक ऑफ चॉइस इज पीडीए. पीडीए is exactly Dr. Monimala, my dear. Today's topic of choice is PDA only. Monimala has a different definition of PDA. Can anyone tell me, how do you define PDA? Anyone? Dr. Monimala, what do you think? How do you define PDA? What is the full form of PDA basically? As everyone knows, yes, that's right. PDA is nothing but patent ductus arteriosus. Dr. Monimala was telling me some other full form of PDA, which she'll be sharing in the comment section. So yes, so patent ductus arteriosus. The commonest question on this planet is patent ductus arteriosus is between what and what? Can anyone answer in the comment section please? PDA किसके बीच में होता है? आपके और मेरे बीच में होता है. It is between what? Can anyone answer in the comment section? Exactly. The most beautiful answer, yes, PDA. So Dr. Monimala says, I say PDA is patent ductus arteriosus, and yes, and Monimala says public display of affection. Public display of affection is not PDA. PDA is patent ductus arteriosus. Okay, Dr. Monimala. Yes. So the most simplest question I have is PDA is between what and what? Can anyone answer in the comment section? A, B, C, D, 1, 2, 3, 4. What is the best answer I can appreciate? This is the first PG question of the class. PDA is between what and what? I think everyone knows about it. Yes, Dr. Faizan says between the pulmonary artery and descending aorta. That's the best answer. Between the pulmonary artery and descending aorta. That is the first basic question on this planet. That patent ductus arteriosus, as I can see in this picture, this one, this PDA, it is between the pulmonary artery and very, very important, not just aorta, descending aorta. Descending aorta. Number one. Number two, very important question I have is very importantly about among the PDA. So see, between the descending aorta and pulmonary artery is perfectly right. Please pay some like 10 seconds on this slide. Can you please appreciate this? The whole thing is the aorta. This is my aorta, number one. Number two, this is the pulmonary artery. This is the aorta. This is the pulmonary artery, number one. Aorta gives a right brachiocephalic trunk and a left brachiocephalic trunk. Listen very carefully, guys. We have, this is the aorta and this is the pulmonary artery. Number one, the aorta gives a right brachiocephalic trunk and a left brachiocephalic trunk. And the left brachiocephalic trunk gives two things, left common carotid artery and left subclavian artery. Very simple, basic, remember, okay? Yes, exactly. So aorta gives a right brachiocephalic trunk and a left brachiocephalic trunk. The left brachiocephalic trunk gives a left common carotid and left subclavian artery. Why I am telling so much? Why I am pushing this line so much? Because one thing I have to remember, that the ductus arteriosus, it is just distal to the left subclavian artery. This line is important. This for again, this is the PG entrance question number 2. That ductus arteriosus, is it proximal to the left subclavian artery or distal to the left subclavian artery? If you can appreciate this, very important, this one, this is the left subclavian artery. Can we appreciate this part, that the ductus arteriosus, it is just distal. It is just distal. I hope you are able to get this beautiful slide, that ductus arteriosus is just distal. This is the left subclavian artery and here is my ductus arteriosus. This is the ductus arteriosus. Okay, so ductus arteriosus, it is just the distal to the left subclavian artery. This is one point you need to remember. In the latest updates of this slide, we had a question, how much distal? How much distal? Ductus arteriosus is just dash millimeter distal to the left subclavian artery, and ductus enters the pulmonary artery at its bifurcation. First of all, can you tell me how much millimeter distal is ductus arteriosus to the left subclavian artery? Can anyone answer in the comment section, please? Dr. Manish Yadav, one of my again favorite juniors. Manish, तुम कल क्लास में नहीं आए, आज आयो bro. कहाँ थे कल तुम? Can anyone answer in the comment section, bro? A, B, C, D. Ductus arteriosus. Good. Okay, good vibes. Okay, we want amazing, beautiful vibes in this class. Imagine you're reading this topic for the first and last time on this planet and you remember everything asked about PDA. Yes, very good, very good. So beautiful people are answering, man. Very good. So Shubhangi Kaushik, very good, my dear. So ductus arteriosus is just 5 to 10 millimeter distal to the left subclavian artery. This is important. These are all my cardiology classes in the upcoming classes. Everything will be new, okay? Some 5-6 new question, different way of approaching. I'm trying my best to read more books and teaching you in a more beautiful way. So ductus arteriosus is just 5 to 10 millimeter distal to the left subclavian artery. Very, very important. Okay, remember, my dear friends. Okay, please, this one, right? I told you this is the left subclavian artery and this is the ductus arteriosus. So ductus arteriosus is just distal to the left subclavian artery. Very, very important. And also now second line is important, that ductus arteriosus enters the pulmonary artery at its bifurcation. I'll repeat again, 1 second, I'll just change the pen color. Ductus enters the pulmonary artery at its bifurcation. I'll repeat again. See, ductus, see, can you tell me one thing, that ductus arteriosus, is it a right to left shunt or a left to right shunt? So the arrow, if this is the ductus arteriosus, right, this one is the ductus arteriosus, no? So the arrow should be like this. Do you agree? Yes or no? This whole pipe, the arrow should be like this. Are you understanding? See, listen very carefully. This is the aorta, no, and this is the pulmonary artery, right? What was the line? The line is ductus enters the pulmonary artery. Are you understanding? I am not saying that pulmonary artery enters the ductus. Are you understanding, guys? I am not saying that the pulmonary artery enters the ductus. I am saying the ductus enters into the pulmonary artery, right? So it means, that is what I am saying. It is a left to right shunt. Okay, it is a, we are talking about PDA once the baby is out. This is not the fetal circulation. I hope you're getting a beautiful picture, right? This is not the fetal circulation I'm talking, because in fetal circulation, ductus arteriosus is a right to left shunt. This is a patent ductus arteriosus. Patent matlab khula reh gaya. Patent matlab means it is opened by mistake. So we are talking about post neonatal circulation, not the fetal. So in a neonate or a preterm baby, once he's born, ductus arteriosus is a left to right shunt. That is why I am saying that ductus enters the pulmonary artery. Are you able to understand this line? Yes or no? समझ में आ रहा है? Are you getting, bro, what a line I'm trying to push it? So that's what ductus arteriosus enters the pulmonary artery. This line is important. So ductus arteriosus enters the pulmonary artery at its bifurcation. At its bifurcation. Because can you see that, like this one? This is the bifurcation. One line is over here. One line is over here. This is the bifurcation, and our ductus arteriosus is just entering the pulmonary artery at its bifurcation. This is one line again, bro. I want you to remember. ठीक है, याद रहेगा. I hope beautiful people are answering, like I hope you guys are remembering in a beautiful way. Great, this part is over. Yeah, very easy question. It's a very beautiful topic, but we have covered, like I have taken this topic from Ames protocol and Nelson, so that's why, like, I wanted to answer me a lot of questions. Okay. Yes, what are the factors causing closure of PDA? Can anyone answer in the comment section, please? What are the factors responsible in the closure of PDA? If this is a 3 marks question for MBBS student, can anyone answer in the comment section? We have done what are the factors responsible for closure of PDA? Number 1, can I write oxygen? Yes or no? Dr. Shubhangi? Yes, very good, very good. Do you remember that oxygen is a good smooth muscle constrictor? Is this line wrong or is this line right? The oxygen is a smooth muscle, is a good smooth muscle constrictor. Once the baby starts breathing, the lungs inflate and deflate, and oxygen plays a very important role. It causes the smooth muscle to constrict, and PDA is a smooth muscle causing closure of PDA. Number 1 is oxygen. Second, any important? Yes, you're right. We have oxygen, we have bradykinin. I have told you. Hanji, Karan, very good, Karan. Bradykinin also helps in closure of PDA. And very importantly, the new pointers which I want you guys to write: catecholamines and even acetylcholine. Catecholamines and acetylcholine, very importantly, I want you to remember. Yes, these are the factors responsible for the closure of PDA. Yes, learn the topic in a very beautiful way, okay, so that the question, if it comes in any way, you are ready to answer. So oxygen helps in closure of PDA. Bradykinin helps in closure of PDA, catecholamines, acetylcholine, and can you please tell me placenta secretes what? I always get confused, bro. Does placenta secretes PGE1 or placenta secretes PGE2? Can anyone answer in the comment section? Very quick answer. Beautiful, good vibes, good vibes. हाँ जी, प्लेसेंटा क्या secrete करता है? Placenta secretes PGE1 or PGE2? Who will answer? Tell me. Yes, you have 5 more seconds to answer. Very good, very good. Karan, Manish, Mukesh, Shubhangi, Grace, Shubhangi again, Faizan, SG, Orion, Awesome, Priya, Vaibhav, Amrit, and Shubham. Yes, so placenta secretes PGE2, right? This is important, bro. Placenta secretes PGE2, which helps in keeping the ductus arteriosus open. This is very important, as we have already told. So these all are the beautiful factors which are helpful in closure of PDA. Next question, please. Incidence of PDA. Is patent ductus arteriosus is more common in males or more common in females? Can anyone answer in the comment section? Quick answers. Quick. Yes. Dr. Faizan is very good. So beautiful. Dr. Faizan is asking that PG even, like he's telling that PG even we give from outside, and the drug is in the PG even. What is the drug? L-prostadil. You know that, right? We have L-prostadil. L-prostadil is a drug which is nothing but prostaglandin analog PG even, which helps in keeping the ductus arteriosus open. I cannot give PGE2 because PGE2 is endogenous. Placenta secretes PGE2, which helps in keeping the ductus arteriosus open. If I want to give something from outside to keep the ductus arteriosus open, the answer is PGE1, that is L-prostadil. Star mark. It has already been multiple times. It has been a NEET PG question. Okay, great. Kavya has a very beautiful answer. So what do you think, guys? The incidence of PDA is more in males or more in females? Yes, exactly. ओहो अमृत क्या बात है. डोज देख, मेरा भाई डोज बता रहा है. And the dose of PGE1 is 0.05 to 0.1 microgram per kg per minute. Very beautiful. Dr. Amrit, very good, bro. So Dr. Amrit is putting an extra point. Let's just finish it off. The dose of L-prostadil is 0.05 to 0.1 microgram per kg per minute, and it is given through infusion pump over 24 hours. It is given through infusion over 24 hours. It could be, it was a super speciality question, the dose of L-prostadil. In NEET PG they don't ask you the dose, but in super speciality exams they ask you. Roughly 0.1 microgram per kg per minute is the dose of PGE1. And the best answer for this question, remember my dear friends, it is more common in females. 1:2, double time, 2 times. So more common in females. PDA is more common in females. Beautiful answer by Dr. Shubhangi Kaushik. Next question I have, it is more common, it is more in low altitude areas or high altitude areas? Can anyone answer in the comment section? Quick, 5 seconds. Yes. PDA is more common in low altitude or high altitude? You have 5 seconds to answer this question. Okay. कौन सा मोड़ आया जिंदगी के सफर में, बस गई तू ही तू अब तो मेरी नजर में. Yes, that's right. So PDA is more common in high altitude, my dear friends. जो बहुत ही ऊंचाई पे रहते हैं, in the high altitude areas, those babies are very more having chances of patent ductus arteriosus. This is one important question. Next, very beautiful slides. It's like a bang on. It's like every slide is a PG question. So one syndrome where PDA is seen. Quick answers, please. I'll give you 5 more seconds. Can you tell me any one condition where the most common congenital heart in dash syndrome is PDA? You have 5 more seconds again. दिल की हर एक धड़कन तुझको पहचानती है, तेरा हो जाऊंगा मैं तू नहीं जानती है, मैं तुझे जान गई हो. Yes, the most common congenital heart in congenital rubella syndrome is PDA. That's very well put. That's a beautiful answer. And can you please tell me what was the triad? Yeah, I always forget. Could you please tell me what is the triad of congenital rubella syndrome? Do you remember, guys? We have something known as torch profile. T for toxoplasmosis, O for others, R for rubella, C for cytomegalovirus, and H for herpes. R for rubella. So rubella का triad क्या था rubella का triad? डॉक्टर शुभम क्या बताएंगे हमारे दर्शकों को कि क्या ट्रायड था कंजेनिटल रूबेला का? यस. ओह दिल. Thank you, Dr. Shubham. Thank you, Dr. Dear Osama. Yes, the cafe coffee day was the triad. The most common, the triad of congenital rubella syndrome, number 1 is congenital heart disease. Then we have the cataract, and then we have the deafness. The most common congenital heart disease in a case of congenital rubella syndrome is nothing but PDA, patent ductus arteriosus, and the most common manifestation, the most common symptom among this cafe coffee day is deafness. Deafness is the most common symptom among these 3 conditions. Okay, that you should know. I hope everyone has got it. Next question, please. Acha, this is a very beautiful line. Today morning only I took that line from Nelson. I went to my hospital. I read for 1 hour PD again from Nelson. This book, Piyush Gupta, every book I read. So okay, this line is important. Can you please read this line verbally at your home and houses? Please speak with me. Say, it is important to realize that PDA in term babies is a structural abnormalities. Repeat again. It is important to realize that patent ductus arteriosus in a term baby is a structural abnormality, but in preterms, it is just a physiological developmental problem. Did you understand this line, guys? Yes or no? I'll repeat. This is a very beautiful line. It is important to realize that PDA in a term babies is a structural abnormality. See, remember, guys, PDA in a term baby. PDA in a term baby, what will be the treatment? And PDA in a preterm baby, what will be the treatment? Can anyone answer in the comment section, please? Does my treatment changes for a PDA in a term baby and PDA in a preterm baby? Can you answer in the comment section, please? Yes, 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 yes. Beautiful, beautiful. That's very well put. That's right, Dr. Shubhangi, my dear. Very good. So PDA in a term baby, it's written, it's a structural abnormality. कहाँ चला गया हाथ ऐसे लग जाता है मेरा एकदम से हवा का तरह. Yes. So please remember one thing importantly, my dear friends. One thing I need to understand is one second. One second. Yeah. So PDA in a term baby, the treatment will only be surgery. Please don't write ibuprofen or indomethacin as a treatment of choice of PDA in a term baby. Okay, remember that. Okay, PDA in a term baby, remember it is not ibuprofen or indomethacin. In a preterm baby, Hanji, you can give ibuprofen. You can give ibuprofen, or what else you can give? You can give indomethacin, right? Ibuprofen, indomethacin, or paracetamol. The best answer, if it comes in exam, the answer is ibuprofen. Preterm baby, PDA open, give ibuprofen. In a term baby, there is no role of ibuprofen or indomethacin in a term baby. In a term baby, PDA open is always abnormal, and the treatment would be surgery, like this what you called you can put a catheterization or embolization. Basically, there's a coiling you can do. You can close the PDA by a coil. Okay, that you should know. Done. Has everyone understood this much? Yes or yes? First tell me this, then we'll continue further. Hanji, Dr. Shubhangi? Yes, the song is nice. थोड़ा सा प्यार हुआ है, थोड़ा है बाकी. यस, समझ में आया इतना या दिमाग के ऊपर से क्या? डॉक्टर शुभम, ब्रदर, डिड यू अंडरस्टैंड ब्रो? आज जिम में क्या किया? कैन यू प्लीज शेयर योर इवनिंग रूटीन्स? What did everyone do? Please, we need to talk. Can you please share your evening routines? What all you guys did? Ate momos, became fat, or anything productive did you do? Yes. Karishma says amazing question. Yeah. So yeah, very good. I hope you have understood. ठीक है, समझ में आ गया. चलो, I'm happy. Grace understood. Amrit understood. ठीक है. Karishma, very good. ओके, ब्यूटीफुल. ओसामा, दिल की बौछार हो रही है. वही बात याद आ गई ना मुझे, जो अब आने वाले हैं वो लगा देंगे स्टेज पर आग. फिर दूसरा कहता है, अरे बाबा कहाँ है आग? अरे नहीं बाबा, जलवे की आग. तो ऐसे करके होता. यस, एग्जैक्टली. yes, great. Okay, Dr. Shubhangi. So yes, number one, I went to gym. Shubham to gym गया था. Shubham ने gym जाना छोड़ दिया. Shubham has become fat again. Okay, anyone? Dr. Amir says he played cricket. Okay, good. I like people who play cricket. Karishma, she went for a walk. Okay, Karishma, that's beautiful, my dear. Karan, sleeping. Okay, cute answer. शाम को सो बैठ के. Yeah, Dr. Priya Gupta has a very beautiful answer. Sir, if a preterm baby presents late, then if a preterm baby presents late, then how will we manage? As in preterm baby presents late with this feature of PDA, you're asking. In a case of PDA, usually in general, in the beginning part only, you will get to know. You will get an echo done. You'll get to know whether PDA is open or not. See, PDA has to be a congenital problem, right? PDA has to be a congenital acyanotic heart disease, right? Within few days, the patient will present to you as some features. Normally, left to right shunt features come by 6 weeks of life. But PDA, in my practice, in our preterms, in our NICU, we have 28-weeker, 30-weeker, 32-weeker preterm babies. So they present you with the hyperdynamic precordium and bounding upper limb pulses, easily palpable dorsalis pedis artery. They present very early. It is very less likely for a PDA to present after 1 month. PDA doesn't present after 1 month. Within 2 days, 4 days, 5 days, the patient having some features of shock and like a bounding upper limb pulses, you will suspect PDA. in my 1 year of residency in NICU in my hospital, like I was in NICU for 365 days, every single day, not even a single C off, no holiday, no CL, no medical leave, continuously 1 year of fellowship, not fellowship, but 1 year of I did my SRship in my hospital in NICU. So PDA we usually used to detect within few days of life, 3 days, 4 days, 5 days old preterm PDA का feature आ जाता था. ठीक है, that you should know. Okay, great. Perfect, perfect. Okay. Dr. Shubham says, I also did shopping and ate pizza and more pizza and momos and pizza. Okay, okay, that's good, bro. That's good. I also did shopping today. I went to Skechers and I got new shoes for me for my gym and they are beautiful. They're very soft. वो क्या बोलते हैं उसको, कुछ hyper burst, कुछ उसमें एक अलग सा suspension है मेरे वाले shoes में. They are amazing. Okay, so let's continue, my dear friends, please. Okay. Finish it off. The next question on this beautiful planet is M1. Can you please tell me, in a case of patent ductus arteriosus, M1 will be loud or M1 will be soft? You know, right? We have S1 and S2. S1 is the first hard sound, S2 is the second hard sound. The first hard sound M1 is because of the closure of the tricuspid wall and the mitral wall, nothing but T1 and M1. And my question is M1. In a case of PDA, can you please tell me? Yes, exactly. Can you please tell me what happens to M1 in a case of PDA? So as you all know that there is increased pulmonary blood flow. There is a more and more blood flow in the pulmonary artery. Do you agree? Normally blood comes from the superior vena cava to the right atrium to right ventricle to pulmonary artery. But as you know, patent ductus arteriosus, as everyone beautifully knows, that it is a left to right shunt. So more and more blood will enter the pulmonary artery. From the pulmonary artery it will go to the lungs, and from the lungs again to the left atrium, and very very important to the left ventricle. So इस वजह करके, that is the reason you will always have a loud M1. You will always have a loud M1 in a case of, very importantly, in a case of PDA. Remember, okay? And do you remember, in a case of ASD, will you get a, what if I say about T1? In a case of atrial septal defect, will you get a soft T1 or a loud T1? Link and study, link, finish it off. You will never forget. Yes, in a case of atrial septal defect, you will get a loud T1. In a case of atrial septal defect, you will get a loud T1. In a case of patent ductus arteriosus, you will get a loud M1. You will get a loud M1. Yes, very true, very true. Perfect. That's right. Let's move further. Yeah, this part is over. Yes. Now the next question. What about the shunt murmur? Yeah, this is a very bang on question, very smart question. Can you please make me revise? I am a beautiful FMG student. Can you please remind me what was the shunt murmur in ASD, shunt murmur in VSD, and shunt murmur in PDA? Quick answer. Let's see who can tell the fastest answer on this planet. Shunt murmur in a case of ASD, VSD, PDA. Can anyone answer in the comment section? Yes? Exactly, very good. So if I talk about shunt murmur, very very important. Shunt murmur in a case of ASD, anyone, what happened to shunt murmur? So in a case of ASD, shunt murmur is absent. That is one thing we understood, because we have a large normally the ASD is a large ASD. Whatever the blood is coming in the left atrium, it directly goes to the right atrium, so you don't hear any sound, it directly all the blood go. So shunt murmur is absent in a case of ASD. What happened? Yeah, Hanji, that's right. And yeah, in a case of VSD, you will have a pan-systolic murmur. You have the shunt murmur will be a pan-systolic murmur, very importantly. And in PDA, anyone, in the case of patent ductus arteriosus? Yes, in case of patent ductus arteriosus, you have a continuous machinery murmur. So shunt murmur is absent in ASD, pan-systolic murmur in a case of VSD, and continuous machinery murmur in a case of PDA. Shunt murmurs are over. Okay, if you write this in a very beautiful way, I mean, you will get all the marks. I'll repeat again. Shunt murmur is absent in a case of ASD. Shunt murmur is pan-systolic in a case of VSD, and shunt murmur, very importantly, continuous machinery murmur in a case of PDA. PDA. ठीक है? I hope you have got it. Okay. Next question. What will happen to the S2 sound in a large PDA? Can anyone answer in the comment section, please? What will happen to the S2? You know, right? We have the first hard sound is S1 and we have the second hard sound is S2. S2 comprise of, very importantly, the pulmonary component, that is nothing but you can say it is P2, and the aortic component, that is A2. So S2 basically second hard sound is because of the closure of pulmonary valves and the aortic valves known as P2 and A2, right? Yeah, exactly. Yeah, now very beautiful point we need to understand. S2, what happens to S2 in a case of large PDA? So very importantly, P for PDA, P for paradoxical split of S2. This is a very smart point, guys. Please remember, you will have a paradoxical split of S2 in a large PDA. S2, second hard sound, I'm asking. Yes, Vaibhav is right, Dilpreet Kaur is right, Grace, SG, Osama, Sheikh. Oh, Osama has written paradoxical split, then he has made a heart and he has split it. Dr. Osama, very बहुत ही भावुक तरीके से आप जवाब दे रहे हैं. Very emotionally Dr. Osama is answering, and Dr. Osama, be ready with a very beautiful quote in the end of the class. I want one poetry from you because your poetry are mind blowing. So one from your side by the end of this class. Okay. Yes, can I please remember the S2 findings in a case of ASD and S2 finding in a case of VSD? So yes, in a case of ASD, we have a wide fixed split. Do you remember this? We have a wide fixed split of S2 in a case of ASD. In a case of VSD, we have a variable split of S2, variable split of S2 in a case of VSD, and we have paradoxical split of S2 in a case of PDA. How will we remember? V for variable, V for VSD, and P for patent ductus arteriosus, P for paradoxical. Okay, so wide fixed split of S2 in ASD, variable split of S2 in VSD, and paradoxical split of S2 in a case of PDA. Now I have, yes, exactly. Okay, great. Now the question is why there is a paradoxical split, paradoxical split of S2 in a case of PDA. Now listen very carefully. Now you have to listen. Great. Yes, exactly. Dr. Amrit says to Osama that your split heart is really creative. Yes, Osama is very creative. So why will you say, sir, I am a new student to your classes. My friend told Anand sir class is okay, you should attend. So I'm attending. Could you please tell me why there is a paradoxical split of S2 in a case of PDA? Now PDA, patent ductus arteriosus, it is a left to right shunt. Number one, as we all know, it is a left to right shunt. This is the left side, this is the right side. It is a left to right shunt. One thing you remember, I'm saying large PDA. I'm not just saying PDA, I'm saying large PDA. Okay, number one. So number one, PDA, we all know it is a left to right shunt. Normally, by eventually what happens? In a case of large PDA, there will be left to right shunt followed by pulmonary vascular obstruction and then right to left shunt. Are you understanding this line? Indirectly, I'm saying in a case of large PDA, there will be Eisenmenger syndrome. There will be Eisenmenger syndrome. Eisenmenger syndrome, nothing but I'm saying there will be a reversal of shunt. Yes, there will be a reversal of shunt. Reversal of shunt means normally PDA is a left to right shunt. Left to right shunt means increase pulmonary blood flow. When there is too much of increased pulmonary blood flow, pulmonary artery starts going to get damaged, nothing but leading to pulmonary atresia, or you can see followed by pulmonary obstruction, very importantly. And when there is pulmonary obstruction, naturally the blood cannot go through the pulmonary artery. The shunt which was left to right, it will become right to left. This is one slot of points we must understand. My question is, what is the S2 hard sound finding in a case of large PDA? The answer is it is a paradoxical split of S2. Why? Because first theory is this: in a case of large PDA, number one, there will be a reversal of shunt, a left to right shunt followed by right to left shunt. So now think very carefully, Now imagine there is a right to left shunt, So as we all know, see, so now the A2 now will close late than the P2. Are you understanding this first line? Think very carefully, please be with me. Normally what happens? Normally A2 closes first, or this pulmonary artery closes first, or the aorta closes first? P2 or A2, which one closes first normally? Normally, as we all know, that second heart sound is because of the closure of the pulmonary valves and the aortic valves. And normally, aortic component closes early than the pulmonary component, because superior vena cava, inferior vena cava is getting the blood into the right atrium and right ventricle. So basically, right side of the heart has to do a lot of work. Okay, so normally aortic component closes early than the P2. This is normal. This is normal. Okay, but now in a case of reversal of shunt, in a case of PDA and reversal of shunt, so can I say that A2 now will close late than the P2? Naturally, are you understanding? So A2 now will close late than the P2. Are you understanding? So that's what this is very important. See, normally A2 close first. Yes. But in a case of large PDA, P2 close first, yes or no? Pulmonary stenosis पहले हो रहा है ना? There is a pulmonary stenosis, right? And then there is a reversal of shunt. So aorta is open, no? So I'll repeat again. Think carefully. Normally, A2 closes first. But in a case of large PDA, I can see pulmonary obstruction. So I can write this line that P2 closes first, then the A2. Now this is known as paradoxical split of S2 in a large PDA. Paradoxical split. See, normally A2 closes first, but in this large PDA, who is closing first? P2 is closing first. Are you understanding? Normally, aortic component closes first, then the pulmonary. But in a case of large PDA, P2 is closing first, and then the aorta is closing, right? So this is known as paradoxical split. होना aortic चाहिए पर हो pulmonary रहा है. This is known as very importantly, yeah. Perfect. Exactly. Yeah, that's right. So this basically is known as paradoxical split of S2. Has everyone understood this much? Yes or yes. First tell me this much and then we will continue. Yes, tell me. तड़पाए मुझे तेरी सभी बातें, एक बार है दीवाने, झूठा ही सही प्यार तो कर. Okay, great. So okay, ठीक है. Okay, I hope you have got it. Okay, I'm repeating for the last time. Because someone said that to repeat again. So कहाँ से मैं repeat कहाँ से करूँ, मैं ये सोच रहा हूँ. अच्छा ठीक है. So the point I'm repeating quickly for the last time. I'm saying in a case of large PDA S2, it's a paradoxical split of S2. What is the meaning of paradoxical split of S2? Normally, sir, we have the this is the pulmonary artery and this is the aorta. Second heart sound is because of the closure of the pulmonary component and aortic component, known as P2 and A2. Normally, aortic component closes early than the P2. This is normal. Normally, aortic component closes early than the pulmonary component, because the right side of the heart has lot of work to do. In a very rough note, if I say, the right side of the heart has a lot of work to do. That's why pulmonary will close little late than the aortic component. So A2 closes early than the P2 normally. But in a case of large PDA, there is a reversal of shunt. This is a PDA, means the shunt which was left to right. Normally PDA is left to right shunt. No, it is a left to right shunt. So left to right shunt followed by increased pulmonary blood flow. Whenever there is an increased pulmonary blood flow, slowly pulmonary artery starts going to damage, leading to pulmonary obstruction or pulmonary atresia or pulmonary stenosis or pulmonary arterial hypertension. So the shunt which was left to right, because of pulmonary obstruction, it is right to left. So now I can say right to left. So naturally pulmonary component closes first, no, because pulmonary obstruction is there, right? Normally A2 closes early than P2, but in the case of large PDA, P2 closes early than the A2. That's what is we need to know. In large PDA, P2 closes first than the A2. So this is known as paradoxical split of S2 in a case of large PDA. तो क्या मैं भाई पढ़ाना भी हिम्मत है, भाई गॉड. Okay. Hmm. Sorry, gold. क्या मैं ओके, लेट्स गो फर्दर। हाँ चलो चलो आगे बढ़ते हैं, आगे बढ़ते हैं। या सो we've covered the shunt murmur. Now can anyone tell me the flow murmur? Just now we covered, एक्चुअली आज पानी भी नहीं है मेरे पास, मैं रखना भूल गया। या yes, yes, Dr. Osama. Yes, you're right, brother. So, just now we covered that the murmur was absent in a case of ASD, pansystolic in a case of VSD, continuous machinery murmur in a case of PDA. This was the shunt murmur. And now we have the flow murmur. Flow murmur in a case of PDA. In general, you remember flow murmur. See, flow murmur, as in what is murmur? You can say turbulence of blood flow. Obviously, murmur, the flow murmur will be due to turbulence of blood flow when the blood flow either through a narrow wall it is going, or excess blood flowing through a normal valve. I'll repeat again. Flow murmur. Murmur as in turbulence of blood flow. You see, normally we have streamline blood flow, streamline. But when there is a mixing of blood, like PDA, someone is going left to right, then right to left. So there's a turbulence of blood flow, right? Turbulence of blood flow is there. Then only you'll get a flow murmur, no? So now the question is, what is roughly you can see the flow murmur? Just remember the flow murmur in the two components will have, you will have in the mitral area and you have in the aortic area basically. So flow murmur in a case of mitral area will be a delayed diastolic murmur, delayed diastolic murmur. Okay, the murmur basically, the flow murmur in the mitral area in a case of PDA will be delayed diastolic, and in a case of aortic component it will be a ejection systolic murmur. It will be a ejection systolic murmur. Yes, exactly. Yeah, okay, remix करने का. Okay, great, 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 very good. ठीक है. Now, yeah, this is what just now I covered this important point. The S2 heart sound, the second heart sound in the case of ASD was the wide fixed split of S2. In the VSD, you will see variable split of S2, and PDA, you will see paradoxical split of S2. Okay, ASD, VSD, PDA, this we have already covered. Okay, again, a quick motivating quote. The quick motivating quote we have is, yesterday you said tomorrow. Okay, yesterday you said tomorrow. So we all are like, kind of, postponing our work. You have to work hard. You have to, if you're opening a very difficult topic, no, tomorrow I will do, Monday I'll do, okay, renal system is very difficult, I'll do it later, neonatology is milestone, oh my god, who will remember milestone, they're so tough, I'll do it later. But yesterday you said tomorrow. Okay, so tell yourself that yesterday you said you'll do it tomorrow, so now don't make any excuses and start working hard. Okay. Yes. Now, important point, very beautiful question. What are the complications a large PDA can lead to? Such a simple, beautiful question. Cardiology is like maths, okay? Cardiology is like maths. 2 plus 2 has to be 4, okay? It can't be 5. So can you think, can you open your brains and tell me, agar large PDA hoga, if there is a large PDA or nothing but a left to right shunt, so what are the complications a patient can have? Can anyone answer in the comment section, please? Yes, exactly. Yes. Okay, अमृत कह रहा है गाना डिसाइड करो ओल्ड वर्सेस ओल्ड न्यू रिमिक्स के लिए. अच्छा जी, ठीक है. ओसामा, एग्जैक्टली, वेरी गुड, वेरी गुड. Okay, that's right. So the complication a large PDA can do, very importantly, beautiful complication. Now listen very carefully. Yeah, Eisen mingerization, yes, that's very well put. Dr. Weber, you're right. Reversal of shunt, the shunt which was left to right, now it is right to left. Yes, that one important. Eisen mingerization complex and reversal of shunt is definitely a beautiful complication of PDA. That's very well true. The other complication we have is it can lead to renal insufficiency. It can lead to necrotizing enterocolitis. It can lead to IVH, BPD, and myocardial ischemia. Now, please allow your brains for this new beautiful information. So we have a ID known as just a doctor. Yes, he says pulmonary obstruction. Yes, you're very right. Large PDA will definitely have a pulmonary obstruction, will definitely have a reversal of shunt. Now, the other important complications, or I would, complication of large PDA are, first listen, then retain, then write. Okay. Large PDA, number one, it'll have an effect on my kidney, nothing but leading to renal insufficiency. It'll have a problem on my stomach, nothing but lead to NEC. What is NEC? Necrotizing, very importantly, necrotizing enterocolitis, necrotizing enterocolitis. It will have an effect on my brain, on my cerebrum and cerebellum, leading to intraventricular hemorrhage. it will have a problem on my lungs, leading to a problem known as bronchopulmonary dysplasia. Bronchopulmonary dysplasia, very very important. Okay, BPD is a super specialty topic, and also when there is a large PDA, it will cause a problem in my heart, that is myocardial ischemia. Myocardial ischemia. So now question point number one, please tell your brains, think. Okay, now tell your please allow your brains for this beautiful extra information. Whenever there is a large PDA, it will have problem in all the organs: kidney, renal insufficiency, stomach, necrotizing enterocolitis, brain, IVH, lungs, bronchopulmonary dysplasia, and heart, myocardial ischemia. Now the question is why. The biggest question on this planet is, sir, once again, the biggest question on this planet is, very importantly, sir, why a patient definitely will have this problem? The best answer for this beautiful point is, it is due to, yes, it is due to ductal steel phenomenon. Now a very very beautiful point, remember. So you know that, right? As we have this very importantly four chambered heart, and then we have very beautifully, we have this one. This is nothing but patent ductus arteriosus, right? Now we know that, right? It is a PDA is a right to left shunt or a left to right shunt. We all know that, right? The shunt flow, the direction will be a left to right. Normally PDA is a left to right shunt. So whenever the oxygenated blood, once it enters to the left atrium and then it enters to the left ventricle, then normally it enters to my aorta. So once it enters to my aorta, most of the blood is going from the left side of the heart to the right side of the heart, because PDA is open, no? So there is a compromised blood flow. There is a compromised blood flow to my whole body. Now this is known as ductal steel phenomenon. Ductus has stolen the blood. Are you able to understand, bro? Ductus arteriosus have stolen all the blood. Okay, whatever the blood is coming to the aorta, before going everywhere, it is just ductus is stealing it out. Are you understanding? So this is known as, very importantly, yes, Dr. Osama, yes. So this is known as ductal steel phenomenon. It's a very beautiful thing. If someone asks you, if the examiner asks you, a large PDA can lead to what all problems in my body? It can lead to all the organs damage, and the best one-line answer for all the organs damage will be a ductal steel phenomenon. Ductal steel phenomenon. Has everyone understood this much? Please put a like button to this video or say a comment. समझ में आया या नहीं आया? इतना समझ में आया? Can I move further? Just a doctor, Dr. Shubham, Osama, Shubhangi, Kaushik, Amrit. हाँ, समझ में आ गया? Yes, this is known as ductal steel phenomenon. Number one, very very important. Yeah, so now can I write this line? It is a phenomenon, ductal steel phenomenon is a phenomenon where a left to right shunt causes, what it causes? Significant retrograde flow of blood from the thorax and abdominal aorta to the pulmonary circulation. Like what he's trying to say, normally the aorta, the whole blood should go normally to the whole body. First of all, ductus is stealing the blood, and whatever blood has gone normally from the aorta to the thoracic and abdominal aorta, that also ductal is stealing. Retrograde. Are you understanding? Allow your brains for extra information. जो blood नीचे गया है, वापस खींच के ductal ने खींच लिया है अपनी तरफ. Whatever the blood has gone to the thoracic aorta and abdominal aorta, the ductal has so much of suction pressure kind of thing is there, it has taken the blood. So this is known as very beautiful ductal steel phenomenon. Ductal steel phenomenon. Yes. So can I say that this ductal steel phenomenon can lead to systemic hypoperfusion? Can I write this line? Does this line make a sense that it can lead to systemic hypoperfusion? Hanji sir, it can lead to. Can I say renal hypoperfusion? Obviously sir, kidney ka problem, yes it can be. Mesenteric hypoperfusion, hanji sir, it can GIT problem. Coronary hypoperfusion, coronary, hanji sir, it will be a problem with the heart also. And myocardial hypoperfusion or dysfunction. So means 100 baat ki ek baat. The bottom line is, because of ductal steel phenomenon, there will be issue in all my body. So a large PDA in a baby, in a preterm baby, can lead to NEC, can lead to all the problems. You know, now you have, are you able to understand, my dear friends? You have to open your brains, wide your picture. Many of our newcomers newcomers think that PDA only specific to heart, the baby will have heart problem, acyanotic congenital heart. But no, now you allow your brains for this information that large PDA, because of ductal steel phenomenon, will have a problem on every system, on every organ. Okay, that you should know. थक गया मैं. ठीक है. Okay, should we continue or you want to break here? So has everyone understood this class? Yes or no? Already 60 minutes are over. Should we continue 5 more minutes, or should we continue tomorrow in the continuing session of 8:30 p.m. class? Please let me know. Yes or yes, 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 yes. Okay, Priya Gupta sir, can systolic hypoperfusion can be seen in a large VSD? Large VSD systemic hypoperfusion is usually like you can, but it is less likely because PDA is like a very strong shunt. It's like a suction. It's like a very high pressure which pulls the blood from thoracic and abdominal aorta. VSD doesn't have that much of power, but PDA has. Okay, that's what the book says. Otherwise, they would have told that ductal steel phenomenon is there in VSD also, in ASD also. No, but they don't have that much pressures to push the blood back from the thoracic and abdominal, whereas PDA is very much down the line and connected to the aorta, right? Very, very close in touch it is to the thoracic and abdominal aorta. That's why PDA has the power of doing suctioning, like a retrograde blood flow, not ASD, not VSD. समझ में आया या ऊपर से गया? ऊपर से बातें देखो, बातें चल रही हैं क्लास में. शुभांगी क्या बातें कर रहे हो? व्हाट आर यू टॉकिंग शुभांगी? ओसामा, शुभम हैं? नए सॉन्ग, पुराने सॉन्ग, रिमिक्स सॉन्ग. बारात आई है यहाँ, बारात मेला चल रहा है, कुंभ का मेला चल रहा है यहाँ पे. हम गपशप बातें कर रहे हैं. क्या कर रहे हैं यहाँ पे? Okay, I hope you all have got a very beautiful picture. I'm trying really my best to share my knowledge, whatever knowledge I have, little here and there knowledge in my brains. I'm really trying my best to share it to you. Even today also, whenever I read something, I always read in a way, you know, कि इसको समझाऊं कैसे, मतलब मुझे समझ में आ गया, इसको समझाऊं कैसे. आई गॉट द कंसेप्ट, बट हाउ ब्यूटीफुली, हाउ इन अ वेरी क्रिस्टल क्लियर, मोती की तरह कैसे इसको समझाया जाए. ऑलवेज ट्राई माय बेस्ट. आई होप यू गॉट इट. यस, या, ग्रेट, perfect. 2 more minutes we will study, then we're gonna end up this class. Okay, so now I have a question. Due to ductal steel phenomenon, so ductal steel phenomenon, I got it, and this and that. So can they compensate by increasing the stroke volume? Can a preterm's baby's body, now you tell me, okay, you're a doctor, okay, you're talking to me, so okay, yeah, ductal steel phenomenon, yeah, NEC, IVH, oh my god, all problems can happen. So okay, how the body should cope up? Either the body can increase the stroke volume. So what do you think, guys? A preterm baby can compensate by increasing the stroke volume. What do you think? What is stroke volume? I have no idea. What is stroke volume? नाम सुना है? कहीं सुना तो था. First year MBBS, I read about it in Sambulingam. हाँ जी, what is stroke volume? Anyone? What is stroke volume? Exactly. Stroke volume is the volume of the blood pumped out of the left ventricle. It is the volume of the blood pumped out by the left ventricle of the heart during each systolic cardiac contraction. I'll repeat again. During each contraction, the volume of the blood pumped out by the left ventricle. This is known as stroke volume. कितना ज़्यादा, with each systole, how much the blood is pumped out by the left ventricle. So that's what the body is trying to, the examiner is asking me a question that as there is a ductal steel phenomenon, can the stroke volume increases, like little more blood pushing out of the left ventricle because of the compensatory mechanism. So can the baby's body do that, or it cannot do that? So the question was, so can they compensate by increasing the stroke volume? The answer is no. A small baby, a preterm baby, cannot do all that. The increased left ventricle volume load is poorly tolerated as preterm have a poorly compliant left ventricle. This is one beautiful line I want your brains to understand, that a preterm baby is fragile and sensitive. So preterm baby cannot compensate the ductal steel phenomenon by increasing the stroke volume. Normally an adult patient can compensate by increasing the stroke volume, the amount of of blood by the each ventricle, by each systolic contraction. Adult can do that, but preterm baby ka left ventricle is very fragile and very poorly compliant, poorly tolerating and all that. So they can't tolerate such hi-fi stroke volume, very importantly. So now the question is, that's what, hence they have a limited capacity to increase the stroke volume. Can is this line understandable? Hence they have a limited capacity to increase the stroke volume, because they don't have a very compliant left ventricle. It is a poorly compliant, इतना दम नहीं है उसके अंदर. Okay, so now the best answer, super speciality question is, how the baby should deal with this ductal steel phenomenon problem. The answer is, they can compensate by increasing the heart rate. They can compensate by increasing the heart rate. That is why the first feature in a case of patent ductus arteriosus is nothing but, documented tachycardia. Documented tachycardia in a preterm baby. If a baby has a documented tachycardia, bina baat ke the bachcha's heart rate, like without anything, the baby's heart rate is more than 160 or like a 160 180 heart rate tachycardia, you must rule out patent ductus arteriosus. You must rule out PDA in the child. And can you please tell me one more cause of tachycardia in a baby? One more important cause of tachycardia in the baby. Yes, Dr. Grace, you're right. Term baby can tolerate that, but preterm can't in general. But term baby, you have to do surgery. Okay, remember that. Okay, Grace, okay, fine. Shubhangi, yes. Karan, yes. Okay, so that's what. Can you please tell me last question, then this class is over. Okay, 60 minutes. I don't teach more than 45 minutes, so this is enough of for your brains. My last question I have is tachycardia. Tachycardia is an important feature. Tachycardia is a feature seen in where else? One is PDA, that's right. Any one slight condition in NICU, we have lot of MD students attending our classes. Or kahan mil sakta hai tachycardia in general? So in a case of shock also, in a case of shock, if the patient is having incompensated shock, there will be tachycardia followed by relative bradycardia. Okay, mama darwaza band kar do mera. So tachycardia followed by relative bradycardia. So number one, in a case of shock, very important, the patient can have tachycardia. In a case of acute kidney injury, the patient can have tachycardia. And darwaza band kar do mera. And also in a case of, very importantly, in a case of PDA also, the patient can have tachycardia करके. ठीक है, that you should know. ठीक है, so these are the important points. Has everyone understood this much? That's what, yeah. So that is one important reason. That is a reason you will see a hyperdynamic circulation, hyperdynamic precordium, as in the bulging pulsations you will feel in the intercostal spaces. Okay, that is one thing you need to know. That's what, yeah. Shock is right. Amrit, you're right. Seizures and patient got tachycardia. Yes, you're right. So in a case of shock, you can get tachycardia. In a case of seizure, you can get tachycardia. In a case of acute kidney injury, you can get tachycardia. If the baby, if the heater is on a very high temperature, yes or no? If the heater of the baby, the warmer of the baby is on a very high temperature, nothing but hyperthermia. Are you understanding hyperthermia? Yeah, then also you can see, definitely you can see a what you call tachycardia in the child. Natural, no? Because the normal temperature of a newborn is 36.5 to 37.5 degrees Celsius. Recently only we had a patient of tachycardia, 178 heart rate, 178. We did ABG, we saw the urine output, everything is fine. Ye bachche ka heart rate, why it is very high? Why? What is the problem? Then later we saw next day the temperature was on 37.9 degrees Celsius. The temperature of the warmer was automatic set to 37.9. So naturally 30 means you are telling the warmer to give 37.9 degrees Celsius temperature to the child, right? That's why the probe is attached. How much ever I put in the warmer temperature, that much only it will transmit to the baby, right? So the whole problem was not shock, not seizure, not acute kidney injury, not PDA. It was just a warmer who was set on a very high temperature. So open your brains. My HOD always used to say that common things are common and rare things are rare. That finishes this class. Last question. Has everyone understood this much? Yes or yes. And as Dr. Shubham told me recently, sir, in the end of the class, just make a quick revision, whatever you told. So in this class, in this beautiful class, point number one, we got to know number one about the PDA. We understood PDA is between the pulmonary artery and descending aorta. Then also we understood that it is 5 to 10 millimeter. The ductus arteriosus is 5 to 10 millimeter distal to the left subclavian artery. Very importantly, then we understood the important factors for closure of PDA: oxygen, bradykinin, very importantly catecholamines, and even acetylcholine also is an important thing which can help in closure of PDA. Then also we saw it is more common in females. It is more common in the people who are living in high altitude areas is important. Congenital rubella syndrome, the most common congenital heart is PDA. Then also we understood one point in it, if a term baby PDA is open, it's a surgical, you have to do surgery. Preterm baby PDA open, you can give ibuprofen, the best answer. Then also we got the various shunt murmur and flow murmur. Shunt murmur in ASD is absent, pansystolic in VSD, and continuous machinery murmur in a case of PDA. That is important. And yeah, these all parts are over. And yeah, and S2, yeah, this is important. You get a paradoxical split of S2 in a case of PDA. We got that also, we understood. And then we understood that yesterday you said tomorrow. So you start working hard today. Okay. The complication of PDA are, we understood it can lead to all the organ problems because of one important thing known as ductal steel phenomenon. And for compensating the ductal steel phenomenon, my body, what will it do? Will it increase the stroke volume or will it increase the heart rate? A preterm baby cannot tolerate a high stroke volume, so increasing heart rate sounds a beautiful answer, and that is why the patient will have a hyperdynamic pericardium or hyperdynamic circulation. That finishes this class. Thank you so much everyone for this wonderful participation. Tomorrow we're going to continue. We have still more very good stuff left for tomorrow's class. In tomorrow's class, we're going to talk about the other important features of PDA, very importantly. Then also we will understand that what is the gold standard investigation of choice in a case of PDA. Then also we'll understand that in a PDA, should we restrict the fluid or not, or also all the important features, ECG findings, X-ray findings, medical management, which one is better, which one is not better. These all things we will talk about it. Dr. Osama Sheikh, do you have some amazing quote to share with us? Dr. Osama, we all are waiting. And thank you so much everyone for this wonderful participation. See you tomorrow again, 8:30 p.m. on this beautiful, amazing cardiology class. Just 1 week more, then the cardiology is almost going to get over. I'm going to take a test very soon of the full cardiology, and we'll take on our Telegram channel, or we'll take on our mobile app, the Pediatrics by Dr. Anand. And yeah, what Shubham says, life is small. Life is small, please visit any mall. ये क्या है ये क्या था डॉक्टर शुभम? Life is small, please visit any mall. Cute, very cute. So Dr. Osama has a beautiful quote to share. Okay, one second, let me just read once. Awesome. So Dr. Osama has a mind-blowing poetry I would love to share with you, but it is in Hindi, so I'm sorry if you don't understand Hindi. So just let's have the quote. हर तन्हा रात में एक नाम याद आता है. हर तन्हा रात में एक नाम याद आता है. कभी सुबह तो कभी शाम याद आता है. I'll repeat again, it's amazing. हर तन्हा रात में एक नाम याद आता है. कभी सुबह तो कभी शाम याद आता है. जब सोचते हैं कर ले दोबारा मोहब्बत, जब सोचते हैं कर लें दोबारा मोहब्बत, फिर पहली मोहब्बत का अंजाम याद आता है. सो माइंड ब्लोइंग. हर तन्हा रात में एक नाम याद आता है. कभी सुबह तो कभी शाम याद आता है. जब सोचते हैं कि कर लें दोबारा मोहब्बत, फिर पहली मोहब्बत का अंजाम याद आता है. Mind blowing, mind opening, mind blowing. It's amazing. Thank you, Dr. Osama. Very very poetic of you. Thank you so much. Thank you guys. Please take care. Love you all. Be crazy. Be amazing. You are the best. You are the best. You're amazing. That's it. No best. You are just perfect. That's it. Nothing else. Okay. As long as you realize your self-worth, it's gonna be a good journey. So try to appreciate and realize your self-worth. Thank you.